Good afternoon, everyone, and welcome. Thank you for joining us for today's webinar, Integration of a Young Pediatric Dental Patient and Behavior Management Strategies. Our speaker for today is Dr. Michael Dowling, and we'll be introducing him in a few minutes. So just to go over a few housekeeping things first, a little bit about Qualidime. So some of you may not know that back in January of this year, Maine Quality Counts actually merged with Qualidime. We are a mission-driven national healthcare consulting organization with multiple offices across New England. We have served over 35 years of experience in healthcare consulting, in improving healthcare delivery. We specialize in quality improvement, project management, and technical assistance. We have served as the Medicare Quality Improvement Organization in Connecticut since 1983 and the Northern New England Practice Transformation Network since 2005. Just to go over a few items in regards to CMEs. Today's speaker does not have any relevant financial relationships with the manufacturers of any commercial products and/or provider of commercial services discussed in this CME activity. CMEs will be available for participants who have signed into the live webinar only. If there are multiple people at one computer, please type their names into the and emails into the chat box for our attendance records so that we can make sure to get you the evaluation form at the end. We do not have separate nursing CEUs, but you can get a CME certificate. I know there will be information later about the dental certificate, so and I know Audrey will talk about that. Once again, this webinar must be ended by the host so that you get a pop-up screen that immediately directs you to the survey. If you end the meeting before we do, you will not receive the link to the survey. So please wait for us to end the meeting. All surveys must be complete within 2 weeks. For CME documentation process, you will be able to immediately download your CME certificate on the last page of the survey. If you have any questions, please contact Jackie Tyner, and her email address is listed there on the screen. So a few more notes to go over. All participants are in listen-only mode, and we ask that you enter any questions you may have throughout the presentation into the Q&A function, and we will make sure to read those to Dr. Dowling at the end of the webinar. The video screen size and icons within are adjustable. So you can just click and move them to whatever suits you. Again, if you're joining by phone or have others on the same computer, it's important for you to put any additional names and email addresses into the chat box. Just to go over our funding statement, this webinar is funded through a contract from Maine Health from the First Tooth. So with that, I will pass it over to Audrey Patton, who is the program manager from the First Tooth, to get us started and introduce our speaker. Audrey?
Hi, Morgan. Thank you so much. I'm just looking to make sure that the slides are going to start being shared before we get started. Thank you. All right, so as Morgan said, the title of this webinar today is Integration of a Young Pediatric Dental Patient and Behavior Management Strategies. With the next slide, we're gonna talk about the objectives. So here they are. So we're going to review and talk about information regarding the importance of an age 1 dental visit. We're going to provide examples on how to integrate a young child, patients within a general practice. We're going to talk about examining the behavior management strategies and techniques, and also to the treatment goals of an early dental intervention. We're going to talk about behavior and modification techniques to develop a rapport with the patient and the parent, and also explain some positioning techniques for examination of a young child. And we'll talk about Dr. Dowling will talk about some scripts for the toddler patient as well as the parent. And then we're going to talk about examination of protocols for the infant and toddler. Next slide, please. So Before the First Tooth is a program here. It first started off from the First Tooth, but our Age 1 campaign really focuses on educating parents and the community members on the importance of the Age 1 dental visit. We really want to recognize and highlight members that are dentists who are willing to see children starting younger than age 1. And we actually have an area on our website, which will be at the end of the presentation, where you can go if you are a dental provider who is willing to see age 1 patients. And we really want to work on facilitating that connection and fostering the relationship between patients, pediatricians, and dentists, so we can have that referral process set in place if there is an issue identified. Next, please. So just a little bit of background information. From the First Tooth has been around since 2007. It was in its pilot years from 07 to 09. And then with our phase 2 in 2009 to present, we actually went statewide. And what our focus is really integrating oral health assessments and fluoride varnishes within well child visits at pediatric and family medicine offices, and also to providing that connection to a dentist's office. Our phase 3 is before the first tooth, and it really focuses on the oral health of pregnant women and their infants. And that started in 2015 to present. Next slide, please. This is really just to highlight what our landscape here is in Maine. The map identifies pediatric dentists in our state, and as you can see, a lot of those rural areas are lacking pediatric dentists, so it's really a responsibility for those general dentists in those areas to see and treat those young patients. A little bit of statistics from the Maine Health Integrated Youth Survey. As you can see, 32.7% of kindergartners and 36.9% of third graders have had a caries experience. And then below, the 17.2% of kindergartners and 15% of third graders had untreated caries. Next slide, please. So today I'd like to introduce our speaker, Dr. Dowling. He's a pediatric dentist here in Maine. He went to Tufts in 2009 and then went on in 2011 to become a pediatric dentist. And he also served on the Maine Dental Association board from 2012 to 2018. So now I'd like to turn it over to Dr. Dowling.
Great, thanks. Thanks everyone for joining us today. Just a quick disclosure, as Morgan already talked about, I don't have any disclosures to make here. I don't have any financial interest in anything. So the biggest point that we want to get out is years ago, the American Academy of Pediatric Dentistry and the American Academy of Pediatrics all came together and said that children should see the dentist by age 1 or within 6 months of the first tooth erupting. I've generally taken that as by age 1. It's a lot easier for people to understand that. So if we can just focus on that, that's really the key here. Those first visits tend to be about talking about nutrition, making sure that everything's developing as it should be. Speech, we're starting to see around age 1. And we want to make sure that permanent teeth can come into a correct position by maintaining the primary dentition. Even before teeth start to come in, we know that we need to begin oral habits. A lot of those first steps are really trying to get parents familiar with putting their hands in their child's mouth. We really want to stress that we're cleaning the gums after they feed, things like that. And as much as we're cleaning, it is a familiarization of the parent with actually working in their child's mouth. It's amazing. We're not afraid to change diapers, but when it comes to, okay, you have to put your hands in a 1-year-old's mouth, a lot of parents get very nervous about that. And that just comes with experience. We know that around 6 months to a year, we want to be making sure that we're assessing what fluoride this child is getting to help minimize their risk for dental caries in the future. As far as setting up that first visit, there's optimal times to do it. Kids tend to do better in the morning, and when they're well rested, we all tend to do that. Oftentimes these kids are, they're not in school, and oftentimes have a parent who's at home with them at least part of the time. So they're also a good way to fill in slower times in an office. So if you always know that at 11:30, there's no one that wants to come into the office. Sometimes these can be good appointments to fit into that time frame there. Typically, we want to avoid late afternoon, early evenings. I know my kids are fairly miserable that time of day, and that's really just everyone's tired. So trying to make sure that we're getting kids when they're at their ideal can help us out there. These visits typically take, we book 30 minutes for them. It's not 30 minutes. That includes time to turn over a room. Assumes that someone might be showing up without their paperwork all done. So 30 minutes is usually sufficient there. Oftentimes parents wonder, if I'm coming to the dentist all these extra times, it's just going to cost extra money. There's a pretty good study that was done, I believe it was in South Carolina, where they looked at the cost of dental care for children who saw the dentist early as opposed to late. And even including all of those extra hygiene visits over the course of 8 years, we saw they've reduced costs there. And that's really because kids that see a dentist earlier on tend to require less actual dental treatment. The first visit that we do doesn't necessarily need to be in a dental chair. In our office, we actually have a couch that we do a lot of these visits on. That's just a lot more familiar for the child. They're not laying in a dental chair with a bright light over their face. We can get some 1-year-olds into a chair, but it's typically a lot better in a less scary environment. I really like using the position that you can see here, where the child's basically sitting on their parent's lap. We start with them sitting up facing their parent, and then they lean back with their head on the provider's lap. In that position, they can see their parent. It's a familiar face, and essentially the parent can hold their hands or comfort them while we're working in their mouth. That gives us really good visualization. We can get light in there if necessary. And it also lets the parent see what we're doing. It's quite often that we're in this position, the parent says, I've never actually seen that before. Those first visits in that kind of 6 to 12 age range, we're always doing, or 6 to 12 months, sorry. We're always doing an examination. One of the biggest things we're doing is looking at what is this individual child's risk for developing decay. Some of it is you know it when you see it, but there are some really good tools from the American Academy of Pediatric Dentistry that helps us classify kids into low, moderate, or high risk. And then we plan our approach for this child based on that individual risk assessment. We are talking to parents about how to actually keep their child's teeth clean, brushing, starting to introduce flossing. It always comes to parents' surprise that you should be flossing your toddler's teeth. Some of that is kind of a desensitization. If they're used to having their 2 front teeth flossed when they have molars that are in contact with each other, and we really do, from a dental standpoint, need to be flossing those, it's not a new thing that we're trying to introduce for a 2, 3, 4-year-old. Again, we're looking at systemic and topical fluoride and looking at what this child's feeding habits are. At this age, I don't tend to intervene too much with what the child is eating. I tend to focus more on how they're eating. So trying to consolidate feeding more towards meals and a couple of snacks, and trying to limit that at nighttime feeding. We also know that kids in that 12 to 18 month range oftentimes will start walking. And with that comes a huge lack of coordination and learning. And they're a lot more prone to injury. So talking to parents about, okay, if your child falls and hits their mouth, we want to be looking at their teeth, make sure everything's okay. Talking about how to create a safe environment at home for them there as well. We also, a lot of times, question comes up of either a thumb or a pacifier for non-nutritive oral habits. I tend to stress that I prefer a pacifier. Pacifier habits are a lot easier to end when that becomes necessary, as opposed to thumb habits. as a parent myself, I know that everyone needs to get some sleep. So most children, or some children, will want to use some kind of soothing device, whether that's their thumb or pacifier. I'll take a pacifier though. We're looking at trying to set the parents up for, as you're coming in the future, these are the things you can expect. We'll try and introduce more and more tools and instruments, try and do more and more of a cleaning. Even if that first visit is a toothbrush cleaning, maybe at the next one, we can start to introduce a prophy angle or a mirror and trying to set them up for that. We're looking at overall growth and development, even if we're not going to do orthodontic treatment on a 1 or 2 year old, but we're starting to see, what kind of growth pattern does this child have, and that should give us the chance to kind of plant the seed of, we may need to intervene here, we may not. That at 6, 7, 8 years old, all of a sudden we're not saying, oh, we've noticed that there was this issue developing and we just never say anything. For children that are medically compromised, consulting with their physician or a pediatric dentist to determine what needs to be done prior to this appointment is very helpful there. Really the biggest thing that we're doing though is building rapport both with the child and with the family, so that they have someone that they trust, they have an environment that they're comfortable coming to visit, so that when something comes up, there is already that implicit support there. Even if you're going to see a child at 1 or 2 years old for their routine cleanings, but you're not going to be managing any kind of trauma, if you have that relationship with them when that child ends up having to see a pediatric dentist or oral surgeon or a general dentist that's more familiar with treating children, having that kind of implicit endorsement is very helpful there. So if you already have a good relationship with them, it can be something of, I know this is kind of a scary time. Your kid just fell and broke one of their 2 front teeth, but you're going to go see my friend who sees kids all day long. They're great. They're going to take good care of you. That's a lot better than someone calling and saying, I have no idea what to do. As kids start to get older, we start to introduce more and more. We're starting to look a lot more at what this child's feeding actually is. Are they wandering around all day with a bottle of formula? Are they wandering all day with a bottle of Sprite? Who knows what? But we're looking at what is, appropriate for this age range. Again, we're looking at fluoride status. Usually we're placing topical fluoride varnishes in this age range. Sometimes that's being done in the pediatrician's office. Sometimes that's being done in a dental home, and checking with the parents of when was this applied. We don't get, for our higher risk kids, placing varnish every 3 to 4 months is a really good option. For our lower risk kids, that 6 to 12 months can be appropriate for some of them too. In that kind of 2 to 6 range, we're starting to kind of repeat what we've been doing, but we're always building. So we're keeping careful notes of what we're able to do at the last visit, and then trying to add in something new each time. I talked about it a little bit, but starting with the toothbrush, then starting to add in a prophy angle. There's some really nice wireless electric prophy angles that work really well and very much resemble a toothbrush that they're used to at home. Things like that can be helpful for something that doesn't seem as scary as coming at them with something that looks like a drill. Sometimes in this 1 to 2 age range, we're able to scale. I'm going to go back here just because I like the picture. This child, I could scale their teeth. That's probably not the case for every 1-year-old. It's a little bit easier because that's my niece, but she probably would do that for anyone. Not every patient, though, is going to let you get away with that. But sometimes, too, if we're seeing gingival problems developing in that knee-to-knee position, we can scale most teeth there. It's pretty quick. You may not get every last bit of calculus, but trying to keep that gum tissue as healthy as we can and kind of continuing to add on a little bit more each time. In the really high-risk patients in this age range, we do think about placing pit and fissure sealants, especially if we're already providing dental treatment, which is an indicator that they are in a high-risk category. A lot of times we can get sealants on primary teeth and newly erupted permanent teeth to try and minimize that risk going forward. We are looking at their kind of orthodontic status as well, whether that's a significant open bite or a significant underbite, things like that. We want to be talking to the parents of, okay, this is something that we're going to need to address. There are some orthodontic treatments that are done in the primary dentition. Oftentimes, we're waiting for at least permanent first molars to be fully erupted, which is 6, 7, 8 years old. But planting that seed of this is the direction we're going to be headed. Also, we know if this is a really ingrained thumbsucker, trying to build that interest in the child of wanting to stop sucking their thumb. That's going to help out a lot if this is a child who's using a pacifier and that's creating orthodontic problems. Talking about when do we really need to stop that by? Typically, if habits end and they're the cause of the malocclusion, then things should kind of go back to where they should be over the course of about a year or so. So even with pacifiers, a lot of times I'm talking to parents of kind of working back in time of, we know that permanent teeth are going to come in around 6 or so. And if we can terminate those habits at least by 4.5, then that gives the alveolus time to drift to where it should be to let permanent teeth come into the correct position. So we're not trying to correct as much. We're looking at things like speech and language development, looking, how does this child compare to their peers? Just because the parent can understand every word they're saying, I typically rely on what teachers at school or in preschools are saying of, they're not quite keeping up with their peers. And if that's an issue, looking at, is there a dental cause for this? Is there some kind of limitation or some orthodontic issue that's creating that problem? Or is this something else? So having those connections with speech pathologists, oftentimes we're talking to pediatricians as well to figure out, is there something we can do to help here? Or is it something we're going to kind of keep an eye on? As necessary, if they need to see a pediatric dentist, an orthodontist, neurosurgeon, a speech pathologist, feeding specialist, whatever, we're making those referrals as well. As far as actually scheduling these appointments go, a lot of it's just waiting for them to call. So the parent makes a phone call. I like to know what I'm walking into. So I'm usually meeting with a hygienist either in the morning to go over what's going on. For most of our healthy, relatively cooperative kids, that's a really quick conversation. But then again, if we have a child that has some significant medical problems, we want to make sure that we're managing those correctly. The parent gets in, checks in, we make sure we have all of their paperwork that we need, that's the appropriate person with the child, and then we've identified who they are. We bring them back to the room, and then we really start assessing what they're up for. These visits, I like to start by talking a lot, and as you're talking with the parent and building their trust, you get to see what this child is going to be up for. Pretty much in all of our cases, we're doing an exam. We're also, some cases we're able to do a full cleaning. Other cases it's an exam and getting some varnish on there. Other times it's just an exam. It's really up to what we're able to do, knowing that we're trying to set a child up for the best chance of having a healthy mouth and healthy body for the rest of their life. So we don't want to create a really negative experience just to be able to say that we scaled some teeth that aren't actually going to create any real problems for the next couple of years. Just trying to create that positive atmosphere. But we pretty much always have to do an exam to make sure there isn't something going on that we need to be concerned about. Kids really feed off of what our energy is. I think that most adults are actually probably more afraid of a toddler than a toddler is of them. If we're comfortable when they come in, if we're having fun, if we're approaching them at their level, kids tend to be a lot more comfortable. We try to always have fun. We're walking in smiling, even if you've had the most miserable experience already that morning. Sometimes it's just standing outside the room for a second, catching our breath and knowing, okay, this is something different. We're gonna try and put on our best show for this child and this family. If a kid is curled up in their parent's lap, then, we're usually a lot more calm. Some kids will run up to us and give us a hug. Other times it's, a much different experience there. One of the biggest predictors of how a child is going to do for their appointment is their parent. If a parent is really nervous, likewise, if we're really nervous, then the child tends to kind of feed off of that, which is why I really try and spend that first couple minutes just talking. Parents oftentimes are trying to put their kid in the chair of, okay, it's time for your cleaning. But a lot of times try and take a step back of, how are you guys doing? What are they into? Trying to find something to have a conversation about that's not related to what we're about to do. And then as the parent tends to loosen up and feel more comfortable and trust us, the child tends to as well. A lot of parents have negative dental experiences in the past. So I'm trying to remind them that dentistry is different now. Just because they've had a bad experience or they're afraid to come to the dentist doesn't mean that their child needs to be. And sometimes it is just actually reminding them of exactly that. Parents usually pick up on it when we're saying, the more calm you are, the more calm they'll be. But sometimes you have to be a little bit more direct of, look, I know you've had a bad experience in the past, but we can do things differently now than what you're used to. And your child is going to be nervous if you are. So try and have a more positive approach here. And then we look at, okay, this child doesn't have the perfect behavior for everything we're about to do. How can we kind of guide this behavior to something that is conducive to providing dental treatment? There's a lot of different strategies here. We're going to go through most of these. When we look at how we talk to kids, I think it's really easy to assume that children can't understand what we're telling them and just ignore the fact that there's our patient here. You oftentimes will just talk to the parent. I talk to my patients regardless of how old they are and tell them what we're going to do. I think everyone deserves that chance. And I think that if we're showing that level of respect for even our youngest patients, then that builds their trust as well. Whether that's a newborn that I'm telling them what I'm going to do, or a 15-year-old that I'm telling them what I'm going to do. I think that showing them that respect, and with that newborn, it might be that the parent hears you say that and explain to them what you're doing. But I think everyone deserves that. We also try and choose very carefully what we say and how we say it. If you just say, open your mouth, most kids are like, why do I want to do this? Generally, young kids want to please you. And if we phrase things more towards what me as a provider needs, then they want to do whatever they can to help me achieve that. So being able to say, I need you to open your mouth so I can count your teeth, as opposed to just open your mouth so I can count your teeth. That tends to work a lot smoother there. We try to use really careful terms that are more friendly. So, I'm not going to say I'm going to use an explorer in your mouth. You should say, okay, we're going to count your teeth, explaining, I have a mirror that I'm going to use to look at your mouth. But I explain it as, this looks just like a spoon. You eat with a spoon. We're going to use a spoon to look at your teeth. Having that better terminology and more family-friendly terminology goes a long way. Sorry. We like to have lots of pictures of what the office actually looks like, and we encourage our parents to go to our website, go to our Facebook page, look and see what your child's going to walk into, so that the parent's not scared and the child thinks of this as a familiar place. We don't like to leave people waiting in our waiting room forever, but ideally having a couple minutes to kind of settle in, play a little bit, get familiar with where we are can help out a lot. And especially for older kids with special needs, I think that having pictures of where they're going to be can bring a lot of comfort for them as well. One of the biggest things that we tend to do is something called tell, show, do, which is this kind of theory that I'm going to explain to a child what we're going to do, and then we're going to show them, and then we're actually going to do it. The best example of this, I think, when we're about to do a filling, oftentimes, they seem scared about the filling. So we show them, okay, this is what filling material looks like. So we're going to use this paint to fix your tooth. Usually I use a sealant because it has a nice little brush on it, as opposed to anything that looks more scary. So, we're going to paint this on your tooth. And then I hold up a finger with the sealant and paint some right on the tip of my fingernail. And then we're going to shine a bright light on it. And we actually cure it. And then they can see, okay, this went to being solid. And then we're going to polish this and whatnot. And then we actually do it. So we're introducing them to what we're doing. Or, we'll use a handpiece. We're going to use this to clean your tooth. I'll take the burr out of it, show them, this is the sound it's going to make. It's going to whistle. It's going to spray a lot of air. It's going to feel cold. And we can show them on their hand, okay, this feels cold. So then when they feel that cold sensation first, it's not scary. Same thing with a prophy angle. You can polish a finger and show them, this is soft. We're just going to use this to clean your tooth off. And then we actually do it. By not just jumping right into what we're doing, it's giving them a chance to settle into the environment. It's also kind of showing them, okay, this isn't actually scary. When that doesn't work, we start to play it a little bit more by ear of, okay, can you tell me what you're scared of? And then oftentimes it's that it's going to hurt. So, we tell them it's not going to hurt. This is how it's going to feel. This is what we're going to do. And then kind of continuing that dialogue. Generally, if you can get a young child talking, then you can build their trust. So sometimes it's just finding what we can talk about. And if that dental related conversation isn't progressing to where we need it to be, we might take a step back and, what's your favorite TV show? Who are your friends? Things like that. Just to kind of open up that dialogue and not being afraid to say, okay, we're going to regroup here. Voice control, I think, is a difficult topic. It's really kind of how do you alter your voice to get the behavior that you need out of a young patient. I think that oftentimes people look at this as I'm going to come in and yell and scare a child to do whatever they need to do. I don't think that is productive for anyone. There's plenty of ways that we can change our voice and become more friendly. In some cases, it is being more assertive, but I don't ever raise my voice. And I think that you also have to look at the parent who's there with their child. If this is a parent who is, or their parenting style is more of a okay, you need to sit here and do this while so we can take care of your teeth. I try to model my approach after whatever the parent's doing. I don't try to change their parenting style. I'm looking at how can I basically embody what this child is used to. There's a study that was released a couple years ago by the American Academy of Pediatric Dentistry, where they looked at our parenting style as a predictor of how well a child will behave for a dental appointment. And they kind of group people into permissive, authoritative, and authoritarian parents. And they basically said that authoritative parents tended to have better behaved children. And I think that's oftentimes because that's the approach that a lot of dentists will take. And if the child is used to that, then you're going to get better behavior. But for the child that's used to more being having more communication in their treatment, or more of a role in their own treatment, that's really not going to work well. So I'm looking a lot at, okay, what's this child used to and what's working? If you're starting to build more and more trust from them by being friendly and talking about Paw Patrol, then keep talking about Paw Patrol. Perhaps more importantly is what we're not saying. We try and get down at their level, whether that's, sitting on the floor with them. It kills my back, but I try not to sit up too straight. The more calm and relaxed we are, kids are going to feed off of that. The parent's going to feed off of that, and the kid's going to feed off of their parent too. I always like to end things on a positive note. We know that we're going to be treating this child for years and years to come. So if we can look for what they did today that was positive, that's going to, hopefully build us more and more cooperation for future visits. Even if it was a challenge, we spent 15 minutes just getting them on their parents' lap, but then once they did, they opened their mouth, reminding of that, and then also reminding the parent to, likewise remind them of that when they get home. So next time when they come in, things will be, okay, last time you did this. So let's basically start there. I'm a big believer in distracting when necessary. No one really likes going to the dentist. There's probably somewhere else that we'd rather be. There's something else we'd rather be doing that's fun. If we can talk about something that actually is interesting, whether that's counting while we're doing something. Sometimes it's okay, I need you to open your mouth while we count to 10, and then we're counting to 10, and they're focused on counting. And parents sometimes will tell stories. I'll tell stories. I won't sing. No one wants to hear that. That's going to be a lot more scary than anything else. But if the child or the parent want to sing, go right ahead. Music, whether that's their own music that they bring along, or just the background music. We've had kids that were really nervous but love one song. And, if we put on that one song, we're going to be able to do what we need to do. I'll listen to whatever kids' music on repeat for 20 minutes while we're actually able to treat them, because probably you're not actually listening to it much. But, talk to the parents of, what are they into? Videos, parents always have their phone with some video on it. Maybe it's a video of that child from last night, or maybe it's some cartoon that they love watching. As long as it's not in our way, we'll have the parent hold up their phone so that they can watch it while we're working. Sometimes it's, having a parent rub or hold their hands while we're working, wiggling their cheek while we're giving local anesthesia, or while we're actually doing any kind of dental treatment. They're focused on my cheek is wiggling as opposed to what's actually taking place in their mouth. We're not trying to hide anything, but if we can focus on something that's more interesting for the child, and And realistically, if you're sitting still for a 15, 20-minute appointment, I don't want to sit still for 15, 20 minutes. I'm struggling to do this already. If we had a experience that's less than optimal, we try to look at how we can essentially restructure that memory into something that's positive. A lot of kids will respond to pressure and mistake it for pain. So we're trying to remind them, like, yes, this felt really tight, or this felt really cold. We're trying to reframe things so that future visits can be a lot more comfortable there. When it comes to changing child behavior or family behavior, I like to focus on essentially one change that we can make. So if this is a child that runs around with a cup full of goldfish all day long, that's going to really increase their risk for developing decay because they're essentially packing these goldfish onto their teeth constantly. So let's try and, we know that your kid loves goldfish. Let's try and have 3 meals and 2 snacks, and those can still be goldfish, but we're doing those 2 actual defined snacks where they're sitting down and eating and then ideally brushing afterwards, but whether or not they do, we have really defined times that they're eating as opposed to just this constant snacking throughout the day. If that's going to be too much, it's looking at, okay, can we make sure that, okay, your kid needs this 10 snacks of goldfish every day. Great, but can we brush after each of those 10? For some families, brushing after each of those 10 might be easier than getting to 2 snacks as opposed to 10 snacks. It's looking for, okay, what's the one thing that we can do? And then when we see them again at that next visit, did we actually make this change? If so, great. What else can we do? Or, is there something that's going to be more achievable? Whether or not parents are in the room, I allow parents in the room. It really doesn't bother me. Some providers do not like parents to be in the room. Some of it is, I think, age dependent. Most 1 or 2-year-olds, with few exceptions, will do significantly better with their parent there because they're not scared. I think that generally parenting expectations have changed, and most parents do want to be present with their child. There's plenty of practitioners that believe they'll do better without their parent there. Some of that is philosophy. If we are seeing kids younger and younger, parents kind of expect to be able to be with their kid because they were the last time. So that's something that you can kind of investigate for yourself if that's a decision that you want to make. But probably 97% of the parents of kids that I see are in the room with their child, and I can count on one hand the number of times it's been a problem. I think that by and large now is probably more of a benefit than to have them there than a challenge, but that's there are other philosophies there as well. We want to make sure that we're being friendly and we have an open dialogue with this family of, okay, what can we do to help improve your child's visits? If a parent doesn't want to talk to us about how or if they're afraid to tell us what they're doing for feeding habits or hygiene habits at home, we can't help at all. The parent needs to feel comfortable talking about what they're doing, that they're not going to be judged for what they're doing. More positive we are there. It's like, okay, this is what you're doing. Let's look at how we can, improve what we're already doing or make some slight changes there. But if they're afraid to tell you, what their oral hygiene practices are or whatever, that doesn't help anyone. Kind of wrapping things up, one of the biggest things is to realize that young kids, just because they're young, aren't necessarily afraid to see us. We need to be as open to seeing them, as most of them are seeing us. If we can create a positive experience early on, we can build years and years of good dental patients. You know, part of that is seeing patients at a younger age, even if it's something that we're not used to, getting those patients in at age 1 to establish a dental home and get them familiar with coming in and using some of these techniques to make those visits as positive as possible can make a huge difference there. And, you know, making sure that we all have the same message that age 1 is the time to see a dentist for the first time. Because if one group, whether that's the Academy of Pediatric Dentistry and the Academy of Pediatrics, are saying age 1, and then a parent calls an office and says, oh, they shouldn't come in until they're 3 to 5 years old, that message has been destroyed. And now, you know, these patients are the ones that end up being treated under general anesthesia that need, you know, 8, 12 restorations, please. You know, trying to make sure that everyone's saying the same thing. And even if your individual office isn't comfortable seeing patients at age 1, saying, you know, making sure that whoever's answering your phones isn't telling the parent, you know, wait till they're 3 to 5. They're saying, you know, kids really should be seen at age 1. We don't see them at that age here, but here's a list of some other local providers that can see them. And just give it a try. You know, if you're not used to it, adding something new to your regular day can make it a lot more fun. With that, I'm going to hand it back over. Try and get off here. And I think we have some questions too.
Yes, we will give it a shot. We've got a couple more things to go over before we get to questions, but don't forget to put your questions in the chat. Dr. Dowling, if you can stop sharing your screen. Perfect. And I realized that I forgot to share my screen the first time around, so you guys missed all the opening slides that I went over, so I apologize for that. But for additional resources and materials, I'm going to put a link in the chat to the website from the First Tooth for you to take a look and find additional resources there. So thank you again, everyone. Here's some contact information for our presenters today, and then our acknowledgement slide for all of our funding for today's webinar. So if we have any questions, please make sure to enter them in the Q&A or in the chat. I actually don't see any at this time. Jackie, do you see any that I might have missed?
No, there were no.
Yeah, I'm actually not seeing any questions yet. So if anybody has questions, please go ahead and put them in Q&A or in chat. I'll just go through a couple more slides while we give it a minute for additional questions to come in. But here are some additional references for today's presentation. And then this is the contact information for any of the Qualitime staff. If you have questions regarding CMEs or upcoming presentations, you can definitely reach out to any of us. And then you can follow us on social media as well, and you can see all of our different social channels and how to find us. And we actually did have a question that came into chat. Can you do a repeat of this training? We're actually recording the presentation, and we will be posting it onto our YouTube channel. And I believe we'll be able to share that in the follow-up email that comes out tomorrow. So be on the lookout for that. Is there a master list for providers? So a question came in, is there a master list for providers that accept main care?
The main care does have a list of providers. We do accept main care. A number of other pediatric dentists do as well. But oftentimes we tell parents if they're looking for someone to call the number on the back of the card, and that does give them a list. The website does have a list too. Some offices have varying policies on age restrictions and what, but that is available from main care.
Excellent. We had a couple come into chat as well. How often do you have children who won't sit still?
That never happens. I think longitude depends on what's your definition of sitting still. You know, I can't sit still. You know, the number of kids that won't, at age 1, that won't sit perfectly still in a dental chair is probably 90-something%. But can we get them still enough in their parents' lap to be able to do an exam and varnish? Probably, you know, on the flip side of that, 90% we can. As kids get older, you know, that ratio kind of changes. Generally in that, you know, 2.5 to 3 age range, most can sit in a dental chair. But there really is no normal. A lot of times parents are asking, you know, is this how kids usually behave? And I don't want them to feel, you know, even if, no, this is not how kids usually behave. You know, if we're saying, oh, your kid was awful, that's not going to build that good relationship. So, you know, I sort of say there's no normal in pediatric dentistry. There's always something different there. And the other benefit is these visits are typically pretty short. So even if this was a challenge because this kid wouldn't sit still, you know, it can usually, okay, you move on to the next one.
Excellent. Let's see, we have another question. How do you gauge what child to demonstrate what you're going to do to versus the child that might get freaked out if you show them too much? So kind of that balance.
Yeah, I think a lot of it is, what do you show them? So I won't show a kid a needle. No one wants to see a needle. For the kid that says, you know, I'm nervous about getting a shot, a lot of times I'll show them a syringe without a needle on it, and then show them, okay, this is a little hole at the very end that we're going to drip some medicine out of. And, you know, show them on their hand that, you know, if we kind of push this edge of where the hub of the needle screws on onto their hand, okay, it feels like a little pinch, so they're expecting that. That can work well. I kind of look at it as, if you're at the point that you're having to do some pretty extensive coaching, you have nothing left to lose. So, you know, I won't show them a drill with a burr on it, and I won't show them a needle. But other than that, I'll show them just about anything. And just because we think that something's scary doesn't mean that it really is. You know, I'll show them counting on their fingers with a scaler or an explorer. I'll use the back curved side as opposed to the pointy side. But I'm up for anything.
Excellent. So there aren't any more questions, but I did want to touch on the question again about a master list of providers that accept main care. You can actually contact the First Tooth, and they can help identify what dental offices are accepting new patients with main care. And that information was on our slides as well. So I will, try to go back to that slide that mentions their contact. Yes. Is it this? Yes. So if you reach out to the First Tooth, Audrey or Elizabeth, they can help you with that information. So I think that's it for our questions. So thank you, Dr. Dowling, for this wonderful presentation, and everyone for joining us. We'll go ahead and close out of the webinar so you can do the evaluation to get your CMEs.
Good. Take care, everyone.